Yay, we're live again. I hate when it's dark like that. Okay. Hey guys, we are here to talk about the fourth trimester. Get it? 1, 2, 3, 4. Fourth trimester with Morghan. So any of you new mommies out there, old mommies,
yeah, people who
fifth time mommy,
have had babies or adopted babies, is applicable to adopted babies. So it's not just the fourth trimester of pregnancy. It's actually the period of time that occurs after somebody has or acquires a baby and adapts to having that baby in their lives. So we're going to talk about the fourth trimester and what that looks like for women. In the United States, we have typically treated pregnancy as if it's a 3-trimester process. And in that last month of pregnancy, you're seeing your provider every week, every single week you're going in and you're connecting with them and you're talking about the birth, like the birth is the thing that matters most, right? The birth, even though it is something that is powerfully influential in women's lives, and it is something that matters, is actually not the biggest thing that's happening on the day that you have the baby. The biggest thing that's happening is you're having a baby, you're becoming a mom. Even if you're already a mom, you're becoming a mom to a new human, and you're going home with that baby. And then what we do generally in this country is remove your care for 6 weeks. So you have a baby, you've built up and built up and built up to this event, like this is the event, and then it's kind of like getting married. You build up and build up and build up to the wedding. You have the wedding, and the day's over, and the climactic moment is gone, and then you have to be married to this person. What is that going to be like? So now you're going home with this little human being, and a lot of it is a lot less than glorious than we're led to believe by, the lovely Instagram posts of cute little babies, and all of the stuff that we can get for our baby showers and the nice little onesies that are now covered in poop and covered in milk and
that lovely sour smell.
a lot of going home with the baby is a lot less glorious than we're culturally led to believe. And we go home and aren't seen for 6 weeks. Our insurance says you don't need to be seen for 6 weeks. You don't need any care for 6 weeks. You've had the baby. You can have routine postpartum care in 6 weeks. And a lot of things have happened. Whether we've had an incision made to remove the baby or whether we've pushed the baby out, we maybe have some changes in our vaginal area or our perianal area. Our body has changed. We've gone from being pregnant to not pregnant, and we've started making milk. And our hormones have changed. So a lot of stuff has happened, and we remove care during that crucial time period when women are having the most changes in the shortest amount of time and not sleeping.
Right. So in that initial 6 weeks after a woman acquires a baby, one way or another, there's, like you said, things that are changing, and there are things that are happening with our bodies and our emotions, and there's a bazillion different things going on that sometimes we don't really know how to navigate, and we don't understand what's going on. And if there are women who are not seen within that 6 weeks, what are some things that they should be kind of looking out for that, maybe they think like, oh, I'm fine, I don't need help with that, or, oh, no, that's normal, or they're going to think I'm a bad parent if I reach out for this. What are some kind of signs and symptoms that?
Well, for the woman's own body, right? She's undergone a lot of changes depending on her mode of delivery. So if she's had a cesarean delivery, she goes home with an incision, and there's a large wound into her belly, and it limits how she can move around, how she can hold her baby, the kinds of things she can go back to doing once she gets home, what it feels like to sit up. It limits a lot of things, the things that she should definitely be working or looking for, and she'll have an assessment. A woman who has a cesarean delivery has an assessment earlier than a woman who has a vaginal delivery in the general system of providing postpartum care, and that's because she does have a surgical wound that needs to be assessed. So typically she'll be seen within a week or 2 weeks after she delivers, and then not again until 6 weeks unless there's something wrong. So they're assessing her incision, not necessarily assessing anything else. Often women go home with babies that they're not really sure how to feed. We do this, lactation support in the hospital, and then it doesn't continue on into the home, when actually in the hospital, the breastfeeding experience is totally different than when your milk comes in, which typically happens after you've already gone back to your house. And so a lot of people are flailing with that. Before cesarean delivery, women should be watching their incision and making sure that it's not oozing stuff, that it's not turning red, that it's not exquisitely painful or getting progressively painful. And then for vaginal delivery, women should be mindful of what their bottom is feeling like. And nothing is going to feel good, right? Like your vagina feels awful after you've had a baby, whether you have stitches or not, but it should not be getting progressively worse. It should not be limiting your ability to walk. It should not be making it so you can't ever sit down. And there should be blood coming out, but it should be tapering off over time. And the blood will be coming out a little bit less after cesarean delivery, just because we wipe out the whole inside of the uterus. So a lot of that bleeding that's in there is diminished a little bit by what we do with a cesarean delivery. You'll still be having vaginal bleeding. In either case, it shouldn't be getting progressively heavy, and it shouldn't smell foul. Then women should watch for fevers, and they should watch for fevers of any kind, even if it seems unrelated to anything, even if it seems to come out of the blue and they're not having any other symptom but a fever. If they're getting a fever where they're shaking from it, they don't need to have a thermometer. They just need to know that that's not a normal thing to have happen. Sometimes you can have hot flashes after you have a baby, particularly if you have a female baby, because you've lost 2 ovaries. So you've lost a lot of estrogen after you have a baby, and your hormones are moving up and down a lot right after you've had a baby. So you can have hot flashes, but you shouldn't have a persistent sense that you have a fever. If you do, then we want you to be seen. The other thing that I think is really, so a lot of lactation concerns, women just kind of assume, well, it's supposed to hurt when I breastfeed, while I'm supposed to maybe not know how to get the baby on there. Well, the baby cries all the time. Now I'm supposed to give the baby formula. There are a lot of lactation things that are much more nuanced that a lot of people struggle with and don't realize they're struggling because they attribute what's happening to a normal situation. And that's regardless of how somebody is delivered, or if their lactation has been induced so that they can feed a baby that they've adopted. There are a lot of lactation things that are struggles for women when they go home, especially when their milk really fully comes in, or if their milk doesn't come in and nobody's really checking in a routine fashion on women to make sure that that's happening in a functional way. And then the other big thing that women should be mindful of, and they are, because we're all mindful of our moods, because we're living with our moods throughout the day, every day, is how their mood is manifesting. So a lot of times we think, well, of course I'm irritable. Of course I'm irritable. I'm not sleeping. Or of course I'm crying because I just had a baby. Or I'm really, really anxious, but I'm anxious because I had a baby. Some of that is normal. Some of it is not normal. And there's just a point at which when it becomes disruptive for the woman, when it's stopping her from doing things, when it's causing problems with her relationships. But that's not always something that's assessed by the provider. Or you get a little checklist. And you go through the checklist and you circle the numbers and then you hand it to the provider. The provider looks at it and says, well, there's no problem, so I don't necessarily need to talk to her about that. But there's a lot of subtlety about postpartum mood changes, just like there is with any hormonal shift and going through puberty. You have kids going through puberty. They're miserable and they
near them.
Everybody is. But the kids themselves, or the person experiencing the hormonal changes, just has them manifesting. It doesn't necessarily identify them as potentially problematic. So that's why I feel like that 4th trimester is really the time that we need to wrap around women and be checking in with them more. Your body, is it okay? Your heart, is it okay? Are you feeling connected to this little human? Are you wanting to throw the human out the window? Which is sometimes fine and normal. Sometimes we are really upset that we had a baby that's now ruined our lives, because there's a huge transition that you're going through. Even if you have this wonderful little miracle of a human being, and you do, and it was very much wanted, it's still ruining your life. And in that immediate postpartum period, in huge ways, stuff has to adjust, and it can be very disruptive on lots of levels, and women feel a lot of guilt about how sometimes they don't want to hold their babies. That's not necessarily postpartum depression. That's just self-preservation. They need to sleep too.
Yeah. So we've seen a lot of women in postpartum, in their 4th trimester. And I know that we've seen women that have come in, and you touched on a couple things there that I would like to kind of elaborate a little bit more on. How it's normal when women come in and they don't want to admit that they're feeling these things. They don't want to, they think like, no, I'm going to sound like a bad parent, or they're going to take my baby away if I feel like I want to shake my baby, or like you said, throw it through the window, or whatever. Or I feel like my baby's ruining my life. But I don't want anyone to come and take my baby. Like, going through those emotions and it being, like you said, very normal for women to feel that way. Is there a point where you feel like a woman should reach out? Should they always reach out? Should they, kind of go on for so long before? I mean, how would you present that to a woman and letting her know that it's okay to reach out when they don't want to admit it?
I think it has to be really individualized, right? Because each one of us has a different support system, and each one of us has a different kind of access to somebody to help us, right? Like, some of us are single when we have our babies and we don't have family around, and depending on the conditions of the pregnancy, some of us have opted to be single and some of us have not opted to be single. So there's a grief process of being a single parent and being alone with this baby. And so really, before you deliver, I think that most women, and then some women have husbands who are deployed, or partners who deploy shortly after they've had their baby, or they, have a deceased mother, and then becoming a mother creates, a whole other wave of emotion that they didn't really know was going to happen. So ideally, prior to delivery, prior to the event that then results in the big event of parenting this person for the rest of your life, it doesn't ever stop. It happens for the rest of your life. It's not just that 4th trimester, but the 4th trimester is probably the most disruptive until they're 13. And then stuff gets way worse.
Then it changes.
Then it gets better. But I think that women, if they tap into, and if somebody asks them about it, which we don't as providers, because we don't have an answer for it, right? Like, we're not going home with you. We can't fix your life. We don't know what's going on, but we don't tend to ask the question about what is it going to look like for you to take this person home. Right. We don't actually ever even talk about it. So we talk about, what it's like to push a baby out, what you might expect as far as your body, the warning signs and symptoms that you should be watching for, but we don't really talk about how's it going to be when you integrate this person. And you can't really plan for it, right? Like, much like you can't plan for a birth. Stuff happens. We can have hopes and dreams. We can have an ideal. We can have an idea of what we want to have happen. We can't really plan for some of the stuff that we just can't actually control. And the same is true of the baby, right? Like, we can't plan for a colicky baby. We don't know if that's going to happen. We can't plan for a baby who doesn't wake up and eat. And loses weight because the baby's not waking up. We can't plan for the temperament of the human. That's the wild card, right? And they come out being whoever they're going to be for their lives. And we can't plan for their behaviors, but we can set up support structures. Even if we're single moms, even if our partner's deployed, we can start to think about, well, who's going to be there to help me? And how am I going to reach out during those moments when I'm really falling apart? Because I'm going to be, and I think people should always plan for the worst and then be delighted when it's better than that. So they should always plan, like, I'm going to be friable, I'm going to be crying, the day my milk comes in is going to be really bad, my boobs are going to be huge, they're going to hurt, they're going to be spraying everywhere, I'm going to think I'm never going to be dry again, and I'm not going to be able to get the baby on there. Who am I going to call?
Right.
Who am I going to call, and who is going to help me? And for some women, it's a partner who's not very supportive. And if they haven't had that conversation before they've taken the baby home, and they haven't set the expectation of, I'm not actually doing the laundry when I come home, right, from the hospital or the birth center or after I've had my baby, I'm not actually going to be responsible for that. Who is? Right. And if that conversation hasn't been had and the expectation hasn't been set that the woman's going to stop doing things that she was maybe doing before and somebody else is going to have to pick up that slack, then it creates a lot of friction between those two people. And so I think setting up a scaffolding of a plan of support prior to delivery is probably the best way to then identify when something's going wrong. Because the woman might just need to take a nap. Right. Like, she might need to come in and be seen. She might have depression, or she might just need to take a nap. And then sleeping for 4 hours straight when she's had disrupted sleep every single night since she had the baby, can repair a lot of things. I think minimize how much that sleep disruption really impacts our moods and our ability to cope with the huge stressor of having this screaming little person who you don't know what they want.
Right. Guessing game.
It's guessing.
And so when women are seen within, sorry, I was reading this comment from Devon here. It was like pulling teeth to get my old doctor's office to allow me to come in for a second postpartum appointment. I'm so sorry. I basically had to beg to come in because I had had a C-section and was having issues healing and with breastfeeding. Ooh. When they finally let me make an appointment and I got to see Morghan, I felt so much better. I appreciated the sound advice and also just getting to hear that what I was feeling / experiencing was normal and that I wasn't a bad mom for having those feelings. Evan, you are right on the same page as so many women. So thank you so much for putting that out there for all these women to see and relate to, because
It's brave.
It's it's more common than women like to admit.
And I know, in response to Devon, I know Devon's situation very, very well. I love Devon. And I know that she greeted a very wanted baby. She wanted that baby. She loved that baby. She planned and planned and planned for what that delivery was going to be like. And then it was not what she had initially planned for. And then going home with that beloved baby, we have so much pressure on us, right, as mothers, to really cherish this desired thing, right? And we do. We love our kids. But sometimes it's actually horrible. Sometimes it's horrible because of what we have to continually sacrifice in order to care for them, especially when they're so dependent, and especially when it's requiring our body to do something when the baby's outside of us. It's actually a little bit easier when the baby's still inside, even though we're uncomfortable and even though we have to pee all the time and even though it hurts to walk or get up. We're not actively having to do something to attend to this person's needs. They're taken care of by that placenta. They're taken care of by our body. It just does it without us voluntarily having to engage in it. And then the baby comes out and all of a sudden we have to do a lot of things for this person who's wholly dependent on us for their well-being. And a lot of that can generate sometimes some feelings of resentment, sometimes some feelings of guilt, sometimes some feelings of regret, like, oh my God, what did I do to my life?
Right.
And if you don't have somebody there and you have an office or a system telling you, no, you actually have to wait until 6 weeks because your insurance doesn't cover this, then you may be floundering and wondering, like, should I never have had this baby? And that can snowball and turn into something that's a big mess and harder to unravel.
Right.
So it's really important, I think, for women when they're feeling things like, I'm not actually okay. And that's all they need to be feeling is, this is not actually okay. I don't feel okay. They don't have to have a particular thought about the baby. They don't have to have a particular thought about harming themselves. We don't have to get to that point. They can just have the thought of I'm not okay. This is not okay. What's happening right now is not okay. And then being able to reach out and have somebody respond to that. And I think that's the most challenging thing, which Devon kind of brings to light, is often then the woman calls in and they say, well, you're really not supposed to be seen until 6 weeks. And that's a payment thing. That's insurance does not want to cover anything outside of that global period. And your provider's office knows that. So they know it's going to be a free appointment, but it's a hugely meaningful appointment for that woman if she's able to get in and get seen by somebody who compassionately addresses and hears what's happening for her and starts coming up with some solutions. So I think some of the reason providers don't want to engage in this is that they don't have a solution. Like, they don't know what to tell somebody to do. Very few providers are actually trained in lactation in a way that allows them to assist in lactation. So a lot of times providers feel like, well, I don't know, there's a breastfeeding problem, but I don't know what to do about it. So I'd rather just not see her. And she should go see the pediatrician, who's also not trained in lactation support. And then they think somebody's going to help the woman with it, but they themselves don't necessarily want to do it because it's not their area of expertise. And as providers, it makes us feel bad to not be able to provide that care. So a lot of times what ends up happening is the woman gets kind of pushed into this corner because we don't want to admit we don't know what's going on or how to help her, and we don't know where to direct somebody for those resources.
Well, with that, you touched on with breastfeeding, and maybe the baby's not feeding and losing weight, and they refer you to the pediatrician, and then the pediatrician maybe refers you to a lactation specialist, and somebody maybe comes to your home, and somewhere in that whirlwind of things, and maybe this is a nipple shield is brought to the table. And I know there's a lot of mixed feelings about nipple shields. Oops, I'm sorry guys, I was trying to get to this comment here.
Well, I think just as with anything, you have to individualize what's happening. So I don't want to vilify anything like a nipple shield, because sometimes a nipple shield is necessary and helpful, and sometimes it allows a woman to continue to breastfeed where she might not otherwise have. Sometimes it allows baby to latch on who wasn't otherwise latching on. It's not in and of itself a bad tool. It is a tool, but I think sometimes we don't know what to do and we're feeling frustrated and we know that this thing exists. We have people implement that without really knowing the ramifications of what we're doing. And I think that's probably true for any intervention that we have. We should know what it's going to do, what the intent of using it is, and how to assess whether or not it's either effective or causing a bigger problem.
Yeah.
So I think there's some additional comments.
Yeah, I was trying to, oh, there we go. Oh, sorry guys. Sorry. Hello, Shannon. Oops, clearly I'm tech savvy. I was not told in our birthing classes that donor milk or formula were an option. Formula was demonized in the classes I took. I felt so lost when my body wasn't producing enough milk. When Morghan told me that it would be okay to switch to formula, I remember crying in her office because I had been so stressed and feeling guilty about not being able to feed my baby with my body. Again, another great thing I'm so glad that she brought up, because talking about breastfeeding and nipple shields and leading into, there's, you know, when a patient is given a nipple shield, there's a reason, like something's not going right. And what are some of, you know, that number one, there are a few things that can make it difficult for a woman to breastfeed, but number two, how maybe it just doesn't work for everybody. Maybe it's okay. Not maybe it's okay, like it's okay that it does not work for everybody.
And it's also okay to make the choice to not breastfeed your baby. It is your body, so you do get to choose whether your body is going to feed your baby or not. And I think that sometimes we get kind of dogmatic. As providers and as healthcare systems, we get kind of dogmatic about what is best and what should happen and what people ought to do. And we make it prescriptive rather than remembering this is an experience that a woman is having that's going to set up her entire parenting of this child and her entire experience of motherhood. And if it is becoming something that is damaging, then it shouldn't be, it's no longer the best thing. And it isn't always the best thing. There isn't a best way for you that's going to be the same as for me, that's going to be the same as for Devon. So in any event, we shouldn't go into any human's experience with an idea of how that ought to happen.
Right.
And I think that we should, as women, not set ourselves up for, and we do, and some of it's cultural expectation, right? Like some of it's all of the stuff that we receive during pregnancy about, like, we should breastfeed our babies, and if we don't, then maybe we don't like our babies as much, or maybe we're not really good mothers, or we should have a certain kind of delivery, and if we don't, then maybe we weren't really that committed to it, or maybe we, you know, we didn't really give birth if we had a cesarean delivery. And I think that we as a healthcare entity, every healthcare provider should not be imposing their beliefs about how something should be done, especially something as intimate as having a baby and parenting that baby and feeding that baby and using your body to do all of it. I think that everything has to be individualized, and we should really be cautious about creating dogmatic ways of doing things. There are some medical conditions that are primarily hormonal or that have created a problem with the production of glandular tissue in the breast where women just cannot breastfeed. And then those are women who are potentially out and about feeding their babies with bottles and feeling judged for doing that when they actually did want to breastfeed their babies and their bodies couldn't supply that food for their babies. So I think we should be really cautious about creating some kind of schematic of what is right or good or best, because that's not going to be true for all individual women.
I think it may be stressful. You don't want to stress about how you're feeding your baby. You know, it's
And if it's not
stressful as it
working,
is.
if that was your intent and it's not working and something's wrong, I would just hope that you're in a situation where there's a provider who's trained specifically in lactation, who can assess what's going on and give you sound advice about what's going on. And I think part of the problem that women encounter is that they're not really sure where to turn, and they're having all of these feelings about it because it's a loaded thing.
Right. And if anyone out there is struggling with breastfeeding or worried about potential struggles with breastfeeding, or has struggled in the past with breastfeeding and is maybe about to have another little one, or anything like that, please give us a call, because we have somebody who's trained and is brilliant in that situation and will do everything in her power to get you to any result that you want to get to. And I know for myself, my second one was extremely colicky, and I was given wrong information as far as what the problem was, and just thought I was losing my mind one day and gave her formula, and it was like a whole new kid, and I was like, that's it. I ain't going back, never going back. So there is no, like you said, I mean, my first kid was different. There is no one way that fits with every situation. How about the fun stuff? How about, post-delivery, not having control of bodily function?
So in particular, when we push a baby out of our bodies, it really taxes our bladder. And our bladder can sometimes descend out of our vaginas. I've seen a lot of women very soon after delivery come back and say, I looked at it with a mirror. The worst thing you can ever do is look at it with a mirror for at least 6 weeks. For at least 6 weeks, you should be looking at it with a mirror, because it's going to look like hell. And it's not going to stay like that, but it's going to look bad. And then you're going to worry, is this normal? Is this not normal? This is scary. Is it ever going to change? I'll always have to have sex in the dark. What is sex going to be like when I go back to having sex? Did I just destroy my entire vagina?
Yeah.
Which is what a lot of people think. And then sometimes, they're standing up and leaking urine, or they don't realize they have to pee until right before the pee is coming out, and it's coming out on the way to the bathroom, and they're saturating their pants, or they're soaking their pad not just with blood but also with urine. And for the first few weeks, that's actually okay, because the nerves that control the bladder and the muscles have attacked so much, they have to recover or repair from that. But women should start almost immediately after delivery trying to stop their urine from coming out. And I think that's something that's missed a lot too, is re-engaging those muscles and helping those muscles recover. And I think sometimes women are told if they don't have a vaginal delivery, they won't have any incontinence after they deliver. But when we do a cesarean delivery, we do remove the bladder from the uterus and push it down and cause trauma to that bladder. And some women have exclusively cesarean deliveries and are still having incontinence because of the trauma that's happened to their bladder. And I think a lot of women think, I just have to live with this. Now I can't cough because I have to cross my legs.
I thought it.
Now I'm peeing on my husband when we have sex. The pee is just coming out. Now I have to meticulously know where every bathroom is and get there quickly, because if I don't go right now, I'm going to pee in my pants and it's going to come out without me being able to control it. And women think that's just like a normal thing that happens after you've been pregnant or had a baby. It's not normal, and it's something that's often not addressed. And I would say sometimes not addressed for 30 years. Sometimes nobody talks about it with this woman, and she thinks it's just supposed to be happening. So if you're leaking pee for more than 3 weeks, 3-4 weeks, it's not getting better after you've delivered, that's a problem, and it does need to be addressed. And it's something that can be addressed without a surgical procedure. It's something that can be addressed pretty easily with just strengthening that pelvic floor and repairing the damage that was done during whatever kind of delivery you had. And if somebody has what's called an operative vaginal delivery, which is where there's a little vacuum that's used to pull the baby out, usually in an emergency, or there are forceps applied, that causes damage to those nerves and structures that are supporting the urethra and preventing pee from leaking out in ways that require more attention after delivery to ensure that that urine isn't just continuously coming out and that the woman's able to get control again.
We can also help with that.
Yeah.
We have non-invasive ways of helping with that. So come use it because I absolutely love it. I also wanted to give a quick thank you to Alyssa on here for sharing her story as well, that she says, we are so thankful for all the work you put into trying to make breastfeeding work for trying to make breastfeeding work for me, just as it was so accepting that it just was not working for me, which is, again, very, 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 very normal for it to not work for everybody. If anybody has any questions or anything, please do not hesitate to throw them up here, give us a call, schedule an appointment. What about one last topic? Do we have time for one last question? What about getting back to sex after delivery? I know that one. Some women just aren't there even after the 6 weeks, and then they feel like they're letting their partner down, or they feel like, they're not back to normal, or whatever they're feeling. It causes some emotions to run through them. And
and there's a lot that's involved with intimacy after you have a baby, and especially if you're breastfeeding, or even if you're not breastfeeding and you have this little human who's demanding something from your body and is on you all the time and wants to be held all the time, and you're getting your oxytocin, which is the love hormone, you're getting your cuddly fix over here, and your husband's trying to sidle up to you like, get away from me, I don't want anybody else touching me, I'm completely saturated with oxytocin and I don't need it from you. And then he's over there feeling like, well, she's crabby all the time, she's leaking all the time, I'm not having sex. They told me 6 weeks. You promised. And there is no right time for somebody to return to sex. I would say if you have reservations about returning to sex, don't do it soon. So if you have a reservation, wait. If it feels like you're afraid of it, wait, because it's not going to be good if you're worried or not wanting to do it. So don't force yourself back into it like, oh, I have to help him so we can. There are other ways to be intimate without him putting his penis in you. And you may not even want to go those ways. You may not want to kiss him because you're getting your oxytocin from your little human and you don't need it from him anymore. So it does create a little bit of a rift in a relationship. And I think it's really important to talk about that before the baby comes, because then that can generate some resentment of the little person or jealousy of the little person, because the lady is so connected with the person and the partner may feel a little bit left out. And when you go back to having intercourse, if you're having penetrative intercourse, when you go back to having intercourse, it might not feel great, especially the first time, and it may continue to not feel great. And part of why it might not feel great is that what happens after we have a baby, and in particular, if we continue to lactate, so if we continue to make milk, our estrogen levels plummet, and we become essentially a postmenopausal woman. And most postmenopausal women are not delighted by intercourse, largely because it's uncomfortable for them. So if it's feeling like sandpaper, if it's feeling like there's no lubrication, if it's feeling painful, if it's feeling agonizing when he penetrates deeper, that's not okay. And that's something that you should be coming in and talking with your provider about. But again, we're not asking about it. And even we see women for their pregnancy, and we see them all the time, and then they have their baby, okay, go home, and then you come back at 6 weeks and we say, okay, have you had sex? No, I haven't had sex. I was waiting for the pelvic exam. You get your pelvic exam. They say, okay, you're fine. Go back and have sex. And then you're not seen for a year. And nobody asks you. And then at a year out, you think, well, it's probably just what sex has become for me. And you accept it as normal. You accept it as the new norm. So I think it's important to feel comfortable with your provider to call back and say, hey, this doesn't seem right, or it feels terrible, or is sex going to be like this for the rest of my life? But you also have to have that open avenue to feel like you can connect with the provider about it.
And I mean, for anybody out there, again, who is maybe about to have a baby or has had a baby and is struggling with some of these things, please do not hesitate to reach out to us. We have, you know, we have so many different resources that we can help with that, you know, we want to make it an enjoyable experience for you if you are struggling with it being an enjoyable experience. I don't want to miss any of these. It's embarrassing. My kid is almost 4 and it's still an issue. I have pneumonia right now and I'm coughing and I'm changing my pants a lot. I think we should do a
Devin, I can fix that.
I was gonna say,
You can call me.
I think we should do a Facebook Live on incontinence.
We got it fixed surgically.
That's awesome.
That's a good option for some people. There are other options for people who don't want surgery. Shannon is asking about the upcoming lactation class. So we are having a workshop. It's about bliss and bummers of lactation. The workshop is on December 2nd. From 6:30 p.m. until 8 p.m. It is going to be at the Skagit Food Co-op, which is here in Mount Vernon. It's downtown Mount Vernon, and it's upstairs in their workshop rooms. They have a big conference area, and that's where it's going to be held. It is free. You just need to register ahead of time. And if you go through the event on our Facebook page, or you go through the event on the Skagit Food Co-op's page, or you go on the website for the Skagit Food Co-op, you can get registered for it. They just like a head count ahead of time, and it's completely free of charge. It'll be a workshop that addresses a wide spectrum of different things for moms who are currently lactating, moms who have lactated, who do want to come and participate, or moms who are thinking about lactating, pregnant and expecting, and want some anticipatory guidance about what's going to happen or what could potentially happen.
Ben, I'm reading your comments here, and I want to know, is it not or is it now? Because I want to congratulate you either way.
Now, she said now she's pregnant.
Well, then she said, I'm not. And then she said, and now. So I wanted to make sure it's now.
And I'm looking for Megan Alder's comment because I see that somebody responded to it, but I don't see Megan's comment.
Oh, no.
Oh, no. I'm so glad you're pregnant. Congratulations.
Oh, no.
That's amazing.
Megan, put your comment in if you're still on there. We would love to.
Still on. We didn't get the comment.
I know sometimes there's a lag on our end. So, oh my gosh, that's so awesome. Hooray! That's so great.
Okay, so we are going to have to wrap it up because we do have patients who are waiting to be seen, and I don't want to keep them waiting in the waiting room. But if there are any additional questions, any comments, any things that you disagree with or agree with, or want to provide support for other women, or looking for support for yourself, and you're watching this after the fact, feel free to leave your comments, feel free to post questions, feel free to call us with questions. If you'd like an appointment, we can always get you one of those, and you're welcome. I think there's no cap on the number of people who can participate in the workshops. So through the Skagit Food Co-op, that workshop will be on December 2nd. It's a Monday evening, and it is free of charge. You just need to get registered.
Starring her.
And then any questions at all about 4th trimester kinds of things. We didn't touch on every single possible thing. We didn't touch on sleep and how do I possibly sleep with this little human being. We didn't really touch on anxiety and what's normal anxiety, what's not normal anxiety. There are lots of things that we weren't able to cover in this short Facebook Live that if you have questions about, we would be happy to answer. And if you have ideas for things that you would like to see in the future on Facebook Live, topics you'd like us to cover, feel free to send those as well. And next week, I think I will be covering the Facebook Live for Dr. Chinn because I think she has a conflicting patient duty next week. So we will be addressing abnormal vaginal bleeding and what that looks like in women's lives.
And answering any questions that you have.
And any questions that you have in the interim, don't hesitate to post them.
Have a great weekend.
Have a great weekend.
Happy Friday.